Hi, I'm Jesse Eichner. I'm a CA2 resident, and we're working together tomorrow. So I've looked up the patients and their histories, and I've come up with plans I think are appropriate. So I just wanted to talk to you about those now. So the first patient is a 20-year-old male, ASA1, here for removal of a ganglion cyst in his right wrist. He's totally healthy, no past medical history, no allergies. He doesn't smoke, drink, or use any other substances, and he's never had anesthesia before. So all I think we need for him is to do a short physical exam and a history, and I think he would benefit from a beer block. The second patient is a 35-year-old male, ASA2, who's presenting for an ORIF of his right humerus. He was in a motor vehicle accident 5 days ago and had polytrauma. He had a fracture to his C6 spine that's now status post-fusion. He also had multiple rib fractures, and he's had chest tube placements. He also had bilateral tib-fib fractures, and he's had external fixations for those. He has a past medical history of asthma, for which he takes albuterol and fluticasone. He is a smoker, and he has a latex allergy. In the field, he was intubated, but has since been extubated, and is currently on 60% FiO2 and is breathing 25 breaths per minute. I can think of several different problems for him that we should be considering. One is that cervical fracture could potentially cause issues with range of motion, so I want to have a plan A and B in place. I'll start with a direct laryngoscopy, and if that doesn't work, then I'll move to a glide scope. He's had injuries to 3 of his 4 extremities, so I am a little concerned about IV access. I want to make sure I have at least 2 IVs, and if I'm not able to get those in his arm, then I'll probably want a central line. Also, as far as the blood pressure management goes, given we only have that one extremity, so I think we should also place an A line as well. And that also has the added benefit of us being able to check ABGs, and that's great given his less than perfect respiratory status. And as far as his respiratory status goes, he has a history of asthma, so I think we just need to make sure that he isn't having any kind of acute exacerbation, and make sure he's optimized as far as that goes, taking his inhalers, and we can listen to his lungs. And then he also has those rib fractures and chest tubes, which can be quite painful and make people's respiratory status worse. He does have an oxygen requirement at this point. So I actually want to ask the pain service to go see him and evaluate him for paravertebral nerve catheters. For his latex allergy, I just need to ask him if he's had anaphylaxis. If he's had an anaphylaxis in the past, then we might need to go as far as taking the rubber caps off of the medications, because those do contain some latex. Thinking about what kind of labs we might want beforehand, I think it's reasonable to get a hematocrit and coags. Trauma patients obviously lose a lot of blood. He's had multiple surgeries, getting transfusions, and so he could have a coagulopathy. I'd like to know what his starting hematocrit is so I can calculate his maximal allowable blood loss. The third patient is a 65-year-old female, ASA3, with sinusitis, presenting for functional endoscopic sinus surgery. She has a medical history of a BMI of 48. She has obstructive sleep apnea and uses a CPAP at home. She also has coronary artery disease, hypertension, and stable angina. Her medications include metoprolol, lisinopril, aspirin, and furosemide. I don't think she needs any perioperative testing, given this is generally an ambulatory surgery and there shouldn't be significant blood loss. Even with a little bit of blood loss, visualization can be very difficult for the surgical team, so they'll often ask the anesthesia team to lower the blood pressure. But for this particular patient and her comorbidities, I am concerned about perfusion. So I want to make sure that I keep the blood pressure within 20% of her baseline. Also, there's growing evidence that propofol can be beneficial in these kinds of surgeries. It can help with decrease in blood loss and visualization. And it would also have the added benefit of being fast off, especially given her obstructive sleep apnea. For her obstructive sleep apnea, she should bring her CPAP with her. Intraoperatively, we should try to minimize narcotic use and maximize other modalities of pain control like Tylenol. Also, postoperatively, we should monitor her very closely for a while and make sure she's not having issues with apnea. And we should have probably a low threshold for admitting her to the hospital. As far as her coronary artery disease, we just need to make sure that she hasn't had an acute worsening of her symptoms. And if they haven't, then I don't think we need to pursue that any further. And for her medications, she should continue her metoprolol, aspirin, but then hold her lisinopril and furosemide the day of surgery.